Order, and at this time we're going to call on Dr. Fitzgerald, our Commissioner of the Department of Public Health, to talk with us about their budget.
With the notion that probably I think most of you were in the joint appropriations, I'm going to go very quickly and simply get to the part where there were some questions asked and see if I can clarify some of the concerns that you had from that meeting. Kate, if you will, if you will simply go to the generalized, the next one. All right, these are the changes that we discussed. What's most important is, if you'll go to this one, the general grant and aid. What's most important is that the general grant and aid, which is the monies that go to the health districts, which is about $57 million, that will not change at all. We were very, and that is, if you keep going. Yes, I'm watching, not you. Not you. Yes, there we go. I'm starting right there. So the general grant and aid that goes to the counties will not change at all. And that's the thing that has the formula that we came to the agreement on about how we were going to divide that pot of money between all the health districts. If you'll look at the next slide, this really describes exactly where those cuts come from. Now, there are monies that will not go to the counties, and that's what this slide is about. $3 million in changes, that will simply come from Peachtree. That will come from administration, and I'll be honest with you, that's going to be hard, but we are absolutely committed to getting the organization as efficient as possible, and we are certainly going to try to do that. Next, you'll see the district and county level changes. These are changes that will apply statewide to all districts. The infant and child essential health treatment services, one is we had one change where we substituted federal money for state money, but that was, I got to tell you, that was the only place that we found that we could bring in federal money and substitute for state money. We really don't have those opportunities very much anymore. And the children's medical services, that equals about 5% of the budget, and our district health directors are telling us that they believe that that will not significantly affect services to children in their districts. The genetic sickle cell cut really has to do with testing supplies. When you have genetic testing, Medicaid will pay for most of those tests. It has not been in the past. We simply have been paying for it all out of state monies. So we talked with Medicaid, and we're going to get as much compensation with Medicaid or private insurance for those genetic tests as possible, but we left enough money in to cover those tests that are specialized tests that aren't done in state. They go out of state, so Medicaid would not cover them, so we left enough money to cover that. So we believe that that will be able to do the genetic testing and take that reduction in our budget. The health check outreach, those monies, that outreach is done by the CMOs, and we thought that might be duplicative, and so we took that cut. The ones then below are the individual cuts that will affect only one or more districts. And these were cuts that were recommended by the district health directors. There is a cut in the Columbus STD program. They do not believe that it will significantly affect services. The next one is the one that had a lot of discussion on during the joint appropriations, and I'm going to discuss that one in detail, and that's reduced funds for hypertension outreach, and I'll come to that in a minute. As you can see, there are 5 locations that currently have those services. And the reduced funds for programmatic grant and aid, that's the Rome foster care program, and again, we believe that Medicaid will be able to pick up those services. All right, so in looking at hypertension, we need to look at what we need to do, and then we need to look at how we can do it. If you look at this slide, you can see, and these are adults who have been told that they have hypertension. You can see that there is a difference in the state of Georgia as nationwide. We have about 32.4% as opposed to 30.8% nationwide, so we do have more hypertension here. All of us know that hypertension is a significant problem. Next slide. If you look at some of the health indicators, infant mortality and low birth weight, you can see that we rank very low in the nation, and that's why the whole joint collaborative project that we're doing with the March of Dimes, with March of Dimes, with the Hospital Association, all those joint programs are aimed toward lowering our infant mortality and lowering our low birth weight. But then you see that cardiovascular deaths, and this is based on America's health rankings for 2012, and you can see we rank 37th in the nation for cardiovascular deaths. So there is no question that hypertension is a significant problem in our state. If you look at the exact amount, if you look at the top 10 causes for hospitalization in Georgia, you can see that number 4, ischemic heart disease, vascular disease, and number 9, strokes, cerebral vascular disease. You can see that they are, of course, affected by hypertension, and it's a significant part of our state's hospital concerns. If you look at the number, this is an aggregate for 5 years. In the past 5 years in Georgia, the number of hospitalizations related to hypertension is 255,143. So it is clearly a significant problem. If you look at the next slide, this is premature death. And these, if you look again in the top 10, there are of problems for premature death. Those related to hypertension are 3 of the top 10. Number 1, which is ischemic heart disease. Number 2, again, stroke, cerebral vascular disease. And number 3, hypertension and kidney hypertension. And if you look at the potential years lost, and this is a 4-year cumulative, we reckon that Georgians have lost 380,000 years of life because of diseases related to hypertension. So there's no question that hypertension is significant in our state. If you look at the program we have to combat hypertension, this was established in 1975 by the Georgia legislature. In 2009 was when it reached the highest amount of funding, which was about $2.1 million. Between fiscal year 9 and 10, that funding was cut by about $900,000, and it has remained at about $500,000 since. So what that means is it's been cut to 1/4 of what it had. So we have 1/4 the money that we had before to combat hypertension. When we had the significant funding, the program was used in 17 of the 18 districts. It was not in Fulton, but that's because Fulton had different funding mechanisms for it. And again, as I said, it is currently now only in 5 locations in Georgia, and that has to do with the lack of funding. If you look at the general trends, and these are monies that are both from the state and from our main federal funders, if you look at between 2007 and 2012, there's been a significant decrease in the basic money, and this is money spent per person in Georgia. You can see there's been a significant decrease in the amount of money. And if you look at the next slide, and this I think is the thing that is most concerning to me, you see that there's been an increase in Georgia's population, but we have had a significant decrease in the number of nurses that we have. And in public health, it is a nurse protocol treatment plan. So what we're looking at is a problem with funding and a problem with lack of nurses to do what we need to do as far as hypertension is concerned. So again, we've reached the point in public health, there are no good cuts. I mean, there simply aren't any good cuts. How we made the decision or the recommendation for hypertension was that we tried to fund those things first, which only public health does, or where it is our primary responsibility. For example, bioterrorism, the ability to screen children for congenital defects at the beginning of their life, that sort of thing. If you look at the next page, again, speaking to the number of nurses we have, looking at national recommendations from our national organization, Georgia now needs over 800 registered nurses. So we really need a change in our workforce, and we've discussed this before. So when we get to the point where we have funds available, that certainly is going to be the first thing that we ask for. So I wanted to stop there and open for questions, because the things I wanted to let you know is the cuts that would affect the individual districts, and also there was some significant questions raised about hypertension. So any questions? Yes, sir.
Okay, I think we've got some questions up here at the front. Who is it? Representative Hughley.
Thank you, Mr. Chairman. Thanks for the presentation. I've had some constituents come to me about the cuts to the sickle cell program. It seems that Columbus had been approved for a clinic, but before it could get off the ground, the cuts came to the program. So can you speak to that at all?
I'm sorry. I'll have Kate look and see. I don't know about that. I'll look that up. Okay. And if we don't have that information today, we certainly will get it to you.
Thank you.
Thank you very much. Right.
Absolutely.
The first one has to do with the formula. Last year when you redid the formula, there were special concessions made to some counties that were losing money, including Fulton County. Mm-hmm. Are they still getting an extra amount to make up for their losses?
They are still getting an extra amount this year. It is not in the governor's budget for next year.
So we should worry about that in the 2014 budget. Question 2 has to do with 3771, the hemophilia issue. I know that we were shifting patients to the
PCIP.
Mm-hmm. Right. And is that why you're able to show this reduction?
Yes. Those numbers are based on the rapidity with which they can do the transfer to the PCIP. And as best we can tell, that should allow them time, to get their patient, because they are moving rapidly into that.
But does that program not end in 2014?
I think that's still up in the air, as best I know.
So, but in the original bill, it was
in the original bill, because in the original bill, of course, there was supposed to be universal coverage, right. And so that probably is not going to occur by 2014.
So Medicaid adults with hemophilia then would be left with no insurance. You think they're negotiating something?
I think they're negotiating.
Well, we'll certainly be watching that.
And that, of course, is with HIV too. I mean, both of those.
Yes.
Both of those programs are significant costs, right. And how we're able to handle those is by putting them in the PCIP program. Right.
Which I thought was going to end, but if you can make it continue, that would be great. I got a couple more. Okay. The early delivery issue. Mm-hmm. I understand from various hospitals and others that we've made significant progress in that.
We have. And Kate, would you turn to that?
By having some volunteer programs in place.
That's correct.
But if we simply cut funding and make it much more difficult, who's going to pay is this going to come out of the doctor? Is it going to come out of the hospital?
Let me see back. Is that one? No, I'm sorry, the one before.
I think it's on page 14.
There it is. And yes, the difference has gone from 65% elective delivery to 4.12. I can tell you this. If there is a medically indicated reason for delivery before 39 weeks, that is not included in the elective delivery. This is only elective delivery. And I know that from the coalition with the March of Dimes and the Hospital Association, we certainly want to take it to zero. And I don't know the funding particulars.
Well, I just expressed that as a concern. Thank you.
Thank you, Mr. Chairman. I have a question and a comment, but one of the things I have noticed in some of the local county health departments have been very interactive with local employers when they are doing wellness and disease prevention screenings and things like that. But other counties either aren't or don't choose, or maybe they're too busy. I don't really know. But I wondered if you have a specific standard or program where you do work cooperatively with employers.
We do not have a standardized program for working with employers at this point. As you probably know, because of the laws of Georgia, the public health departments is really a coalition. and I can tell you that since becoming a department, there's been a lot more standardization than there ever was before. And certainly, we are meeting on a monthly basis with the health directors now, and we're doing things like sharing best practices. And the goal of the department is to have more public-private partnerships and to learn from those public-private partnerships. We do not have a standardized program now because, again, by law, it is a collection of health departments, not just one department.
Thank you. It is very beneficial, and it adds a great resource. It opens up doors to people that didn't realize what all you did, and I think it is very good, and I appreciate the efforts of those that have participated.
Thank you. I think it's great, too.
Thank you.
And I think public health does it better than just about anybody else. I mean, that's sort of our sweet spot.
Any other questions? Anybody? Can I ask one first? Okay. Dr. Fitzgerald.
Yes, sir.
You alluded to the shortage of your nurses, registered nurses and everything, and my question is this. Obviously, it's a function of funding, too, but if you had the funding, being a health professional like you are, could you fill those positions? Are there enough nurses out there, I guess, is my question, to be able to?
I think that's a hard question, and you're right. I think that we certainly need more nurses statewide. I think that we can fill, what we've done is we've had a task force looking at workforce development in public health. And we've not had a career ladder. I'm sorry. Thank you, Kate. I couldn't remember the word. Had a career ladder for nurses before, and now we have established that. I think that we certainly are not as competitive as we need to be with our salaries, but having the career ladder is good, and also public health nursing is really great. I mean, public health nurses love it. It's interesting, and it's a lot more fun than a lot of other nursing jobs. So like right now in North Georgia, I mean, the public health nurses are responding to the tornadoes right now. So there's a lot of interest in nurses, I think, being attracted simply because of the quality of the work and the fun of the work. And I'm not sure we could fill every one of them, but I know that it is almost impossible to fill it without competitive salaries.
Representative Garner, you have another question there.
Thank you, Mr. Chairman. Last year, you talked about initiating a program to keep track of maternal morbidity. Have you learned something about maternal morbidity in Georgia, and is there something we should be doing about it? We did initiate that, and we are tracking that. I can tell you that the numbers in Georgia are higher than in a lot of other states. We have a task force that's assigned to that right now, but they haven't completed their evaluation and come back to us. As soon as they do, we will give you that information.
Any other questions? Well, obviously, Dr. Fitzgerald, you've done a good job. We appreciate you and your team being here and sharing that with us.
Thank you. And if anyone missed anything from the joint presentation, I'll be glad to give you individual updates.
Good. Thank you. Next, now we'll hear from LaShawn Hughes. She's the Executive Director of the Georgia Composite Medical Board.
Thank you, Mr. Chairman. We're the Georgia Composite Medical Board. We license physicians, physician's assistants, respiratory care, orthotists and prosthetists, and perfusionists, and acupuncture. I forgot those. We have two line items, 17.15.1. We cut $1,132 from our telecom budget and $41,824 from personal services. The board is kind of unique. We are not like other agencies. We don't have programs to cut, so we license and we discipline. So we've taken all of the cuts we could take, so our last effort is to take it from personal services. That's it.
Short and sweet, huh?
That's right.
Okay. Any questions? Thank you, ma'am.
Thank you.
Well, our thanks to our presenters this afternoon. We appreciate you being here and bringing us up to speed on what's going on in your department with the budget works. We thank our colleagues in the House and the Senate for attending our Joint Medicaid 101 meeting, and for our committee members for the budget presentation this afternoon. Thank you very much.